Thanks very much. We're all quite good at the human factors, non-technical skills stuff in this service, but I think it's helpful to revisit it from time to time and go over the concepts we're familiar with and see what else is new. I don't just work here, I also work in ICU and, of course, my favorite place, the emergency department. Now, working in ED and here in ICU, I see similarities in jobs that go well and jobs that don't go quite so well. And after a while, we do realize that the clinical stuff is the easy bit, and it's the non-clinical stuff, the non-technical skills, the human factors, the making stuff happen that is the real challenge. And what I want to do in this short talk is just go over 5 concepts that will help us nail a resus even more smoothly. And in the process of that, I'm going to tell you about an amazing woman who was born in 1878, and she still influences the way you do everything from a resuscitation to how you organize your fridge. So the 0-point survey is something to think about when we are managing a resuscitation. Of course, the opportunity to make that job go perfectly does not present itself at the first time we see a patient. The opportunities to make that job go well are present when we're on the way to scene, or when we're having morning brief, or when we're deciding whether to have a drink the night before the early shift. The 0 point on the clock to make the job go smoothly is any of those times prior to meeting the patient. And so before we do the CABC of trauma, we think about the step of 0-point survey and the conceptual map of all the components of the 0-point survey is something we go into detail in induction. And also we do it with ICP training as well through our ambulance. But there's a video that goes through each step in a lot more detail that you can access at another time. And in fact, all the slides from this talk, if there are references that you want to follow up, are available at the end through a QR code, okay? Right, so 0-point survey, you already know, but let's think about a component of it, about getting teams on the same page before we meet the patient. And that's this idea of a good pre-brief and the concept of relational coordination. So there's different ways we can get our team on the same page so we know what the plan is when dealing with the challenge ahead. Here's one example of how some people do it. Carl, no sound?
No sounds coming through the speaker.
Sound is exporting through HDMI, but should I turn this?
It is a known issue with this.
Okay, so we're not going to have sound?
If you need to change the sound to come out of your speaker from your...
Oh, just from here? Okay, because it won't come out of the HDMI. No problem.
Sorry.
That's all right. All right, that was a temporary flow disruption, which we'll talk about later in the talk, actually, but here we go. How to do a pre-brief.
Best way to fucking stick it up everyone's fucking ass is to take this fucking off. Can you feel it now that we've got it? Stop it! And do nothing. We've got to run the play now, so we can take this fucking guys sticking up their fucking ass because there's nothing. Look at each other. Look at each other in the eyes. You see the fucking desire there. Fucking tank. We take this game away from these guys and take the bacon home. Fuck these guys. We're gonna run it.
So that was recorded in the helicopter on a job I was going to with Cameron Marks. So that's one way of sharing a mental model, a pre-brief. But there are other ways that have been formalized. And there's this lovely concept of relational coordination theory. And this has been described at an organizational level. High-performance organizations share these factors to get teams to work well. And that is that everyone has shared goals, kind of macro goals about what they're all about and how they're going to work together. Shared knowledge about what the challenge is, but also knowledge about what each other can do. And then the idea of mutual respect, so you can communicate effectively together and work together harmoniously. So they've been described at an organizational level, on a macro level, but they can be applied on a micro level with an individual resuscitation. And you can do relational coordination in the moment to get your team to be more highly functioning. And this has been a result of work by Vic Brazel and Eve Purdy, two amazing emergency physicians who work in Queensland. Vic Brazel is an absolute simulation guru, and Eve Purdy is an anthropologist as well as an emergency physician. And so her observations and descriptions of human nature and how they relate to EDs and teamworks are really interesting. And she's got several great publications on that theme. And they've taken the pre-briefing that's described by Chris Hicks and his trauma group in Toronto, and they've mapped it to relational coordination domains. And this paper is actually worth reading when you get time. But the idea from Chris and Vic and Eve is that the pre-brief, so you're on your way to a mission or in the ED when the bat phone goes, you make sure everyone knows who's there with introductions and who can do what. You describe what we know: motorcyclist, GCS 14, chest injury, ETA 10 minutes. What we expect, well, we expect, that this patient might need thoracic surgical interventions, will need an EFAST, etc. But what might change? Well, his GCS 14, so he might have a TBI, and in fact, his GCS might have decreased by the time he gets here, so we may have to do an RSI. Let's get set up for that. Roles, who's on airway, who's the airway assistant, etc. And then an opportunity for the team to make any suggestions or express any concerns. And doing all this each time creates that relational coordination. Everyone's on the same page with shared knowledge, shared goals, and of course the mutual respect about who can do what. And we build quite a lot of this in induction when you think about it. We have a lot of paramedic physician cross-training, which creates shared knowledge, shared goals, and mutual respect. And that's one of the contributions to our successful team flow on most of our missions. Another way that's been described for pre-briefing is for services that are new and have more ad hoc team members who won't have had the chance to go through induction the way we have, where we standardize so many processes. And this was recently described in a new German HEMS system that was set up. And they do their 7-4-7, 7 items in 7 minutes. They do every morning morning brief. And for those of you that can't read tiny German, there's a couple of kind of non-clinical things and then a bunch of clinical things. And the non-clinical things are what we're going to do if there's a major incident in terms of role allocation and resource utilization. And the second one on the non-clinical is if we go to a cardiac arrest and we've got limited personnel, in what sequence are we going to do things in terms of, the ABCs and the ultrasound, the CPR and so on. And then the medical things down the side are how they're going to do their RSI, what drugs, what setup. If they have to do a surgical airway, how they're going to position and manage that. If they do chest interventions, how they're going to do that, talk through a thoracotomy, pediatric stuff. And then the last one is interesting. It's almost a non-technical one, I guess, which is any individual preferences, specialist areas, or particularly limitations. What the HEMS doctor there might say, I haven't really done a lot of peds. I don't do that in my hospital practice. I'm a bit anxious about that. We go over the peds reference cards or whatever. So we don't do that because that stuff's kind of taken care of through standardization and recruitment to some extent. But that's an interesting adaptation of a pre-brief done by one service to optimize safety. Okay, so that was the second concept, the relational coordination. Third one is mental models and setting trajectory. So we build this into our primary survey under the team aspect. We optimize self-team environment, we manage the patient, and then after assessing the clinical and logistic components, we come back with an update of this is what's going on, and this is the plan. So, spelling step up, and we're all familiar with that. But we talk about sharing mental model as though it's as simple as making a statement. Right, guys, this is a cardiac arrest. Let's start CPR. But that's fine. That's sharing a model. That's an update and a plan. But mental models are actually more than just a static picture of what's going on. And they're extremely dependent on who we are and where we come from and how we manage information. So to break down this slide, you've got your mental model on the left, their mental model on the right that you're working with. And a mental model itself is a description of what's going on, an explanation of what that means, and then a prediction of what is likely to happen or what needs to be done. So it's a dynamic, four-dimensional representation of this little bit of space-time. It's not a static picture. And how that 4D moving image appears in your brain depends on how you perceive information, how you encode the information, how you store the information, and how you retrieve the information. And all that is influenced by your own experience and your own knowledge and your culture and your language and your expectations. So mental models are actually really subtle, complex things that we can't, by our own volition, instill accurately in someone's brain with a single statement. And I was at the wrong end of this recently at a cardiac arrest case I went to on the pre-care car, where we clearly weren't sharing the same mental model as the paramedics on scene. And we had always a step behind, weren't they? Well, in some ways they were in front. They were just different. They just had a different mental model from us. And so it felt like a messy job. And at the end, we did a debrief, which I thought went really well. And then subsequent feedback is the debrief did not really land at all. And we still weren't sharing a mental model. And so we had subsequent meetings since then. And that really made me think about me saying this is what's going on and this is what I want to happen. It's not really necessarily effectively sharing a mental model. It's an attempt to share a mental model. But we really got to take into account whose brain we're trying to instill that mental model in. Yeah, so to give a bit more substance to that situation, we wanted to focus on specific interventions that might be of value that went outside paramedic protocols. Their mental model was all about high quality CPR and not interrupting that. So our interrupting of what they wanted to do did not meet their expectations or their prediction of what would happen to the patient. And so we really weren't on the same page. So that was a great learning point for me, having thought about this stuff for a long time, and an incentive to look into mental models in a bit more detail. And the point of presenting it here, sharing it with you guys, is that sometimes if things aren't flowing or you haven't got your message across, it is because of that complexity involved in sharing a mental model. And we might just need to try a little bit harder to understand the frames of the people we're working with that can then help us share the mental model more effectively, think about different ways or different descriptions to do that. Okay, hopefully that makes sense. Feel free to interrupt and ask questions at any point or challenge things as well.
Can I ask, on your reflection of that situation?
On your reflection of that situation, what would you have done differently if you were able to do it again?
Yeah, so if I went to that specific job again, I would stand back for longer and get a feel for who's doing what and what they're trying to achieve and how they're communicating, who's who. And then make suggestions rather than commands. And with those suggestions, I think the most powerful thing would be to give the why, to acknowledge what I think their mental model is, why mine is different, and try and sell it rather than just assume that they trust me and know that, that they trust me and expect that I'm providing a more qualified set of options, because they didn't. Yeah, so I think give the why, be more of a salesman, is probably the take home for me. Right. Number 4, the after action review, and one specific way of doing it called the stop 5. This is a bloke called Jack Lancaster. You can tell that he's from the olden days, and he was actually from Basingstoke, which is where I worked as an emergency physician and intensivist for 5 years. In fact, I remember seeing him around actually when I was there. I was there quite a while ago too. Anyway, he did essentially what was one of the first described controlled clinical trials in medicine. He sailed 4 ships there. He sailed 4 ships from Tor Bay in the south of England down to Table Bay in southern Africa. And 3 of them were like normal ships, but the 4th one had fruit on it, had lemons. And when he got there, the guys on the lemony ship were all fine, and the guys on the 3 other ships all had scurvy, and a lot of them died. All right. So he was a smart guy, and he said, right, we should probably provide citrus fruits to people on ships to prevent scurvy. And so he forwarded that up the chain of command, and the British Empire adopted that within its navy 264 years later. So he did the sailing in 1601. So that, in terms of like knowledge translation into practice, there was a bit of a delay there, 264 years. And we need to make sure that we don't do similar things. Who's this guy?
Sully.
Yeah, Sully. Who's this guy? Sully. Yeah, it gets confusing, doesn't it? Anyway, but this Sully, he's the guy that had a bird strike in his Airbus A320, I think, and crashed into the Hudson, and everybody survived. And that was pretty cool. But what he said at some point was, we have purchased at great cost lessons literally bought with blood that we have to preserve as institutional knowledge and pass on to succeeding generations. We cannot have the moral failure of forgetting these lessons and having to relearn them. And you can just forget anything to do with aviation and just map that onto resuscitation. And it's the same thing, isn't it? We have to learn from every time we manage a sick patient, particularly if we lose that patient. And so the way we do that, obviously we have coffee and cases, we have M&M, but we don't always have an immediate after action review, an immediate post-mission debrief. And these are very common practice in high performance organizations across multiple domains, whether it's a special forces military team or a successful business or highly performing school or sports team or even improv comedy groups, okay? They all have the after action reviews. What did we do? What went well? What can we learn for next time? And there's good evidence from the emergency medicine literature that hot debriefs can improve all kinds of aspects of team performance and system performance. And so we've adopted one at Northern Beaches Hospital called Stop 5, which is taken from work done by a group in Edinburgh who invented it. And 5 for 5 minutes, because it's a hot debrief and people are busy and they've got to get ready for the next resus. S is summarize the case. T is things that went well. O is opportunities to improve. And P is plan or action points. Okay, we found some opportunities to improve. Who's going to do what? And we do stop 5s all the time at the beaches. This is for a pediatric case. The big dude on the right is the director of peds. There's Tom Evans running one after a cardiac arrest. Make sure the paramedics are involved. Here's one out in the ambulance bay, so we can make sure we're capturing all the paramedics for a stop 5 there. And our nurses have really taken this on board and have presented it at conferences and stuff. And the beautiful thing about the way it works at the beaches is that the clinical educators come and vacuum up all the completed stop 5 forms on a Monday morning for the previous week, and then go through the action points and action them. And so at M&M, we might say, oh, we had a cardiac arrest and this bit of equipment failed, or no one knew how to use this, but we did a stop 5. And then the nurse educators go, yeah, we've resolved this. We've instituted a training plan and a quick reference guide, and we've taken all the resus nurses through this equipment now. So the monthly M&M, it's not here's a problem, here's a plan, let's review it next M&M. It's here's a problem, a stop 5 was done, the nurse educators have sorted it, it's no longer a problem. All documented at the same monthly M&M, which is, blows me away. I love it. I love hearing that, these kind of problems with solutions immediately at the same meeting. So I don't know if that's something we should be doing more formally in terms of having a structure to our post-mission debriefs. Even when we, capture a bunch of paramedics in Westmead Ambulance Bay and go through a hot debrief there, having some standardized structure to it and even documenting it might be a good idea. If someone wants to think about that more or take that on. All right. The final concept I want to cover today is flow disruptions and how we engineer our way out of flow disruptions. So me not figuring out the audio properly before the talk resulted in a flow disruption to delivering this talk. That was a nice example that I deliberately embedded there for your education. So here's a scene from a previous induction and shows you or equipment organization. And you can imagine if you then want to go and do something at head end, it's going to be hard to get to the patient. So you've put a disruption to flow there. And they can be environment or equipment related, or there can be all kinds of reasons why flow might be disrupted, like this crowded pediatric resuscitation scenario here. But the definition of a flow disruption is any deviation from the progression of care that can compromise safety or efficiency of a specific process. And these have been described in the medical literature in neonatal resuscitation settings on maternity units, in the trauma bay in EDs, and in cardiovascular operating theatre, where there's at least 3 good, interesting publications. And what they show through these observational studies is that little minor flow disruptions add up and result in major flow disruptions. I was at a cardiac arrest resuscitation in the ED. It was a dialysis patient who had an AV fistula in the left arm. So nobody wanted to go in that arm for vascular access, which was a learning point for the team because they really could have in a cardiac arrest. But so everyone was around the right arm, which is also where they were trying to do the ultrasound from. Which is also where someone was trying to put in a femoral art line. And because all the infusions were going in post-ROSC through this right arm, there was a drip stand with the infusions on that drip stand, which was in the way. So the person trying to do the femoral art line, she was trying to maneuver around the drip stand. And I was watching this and I was just couldn't stop thinking of flow disruptions, having just read a lot of literature on it. And before, we'd have clocked it would be an environment thing as part of the 0-point survey, but really understanding why environment is so important in terms of flow disruptions. I'm thinking every time that person moves around that drip stand, that minor flow disruption is a cognitive load for that person, and it's a delay to care. And the cognitive load adds up. And the more flow disruptions there are, the more clinical errors get observed in these observational studies. And the more they accumulate flow disruptions, the more you deplete the cognitive resources. So it is exhausting. And we can all think of jobs, pre-hospital jobs, can't we, where things were just hard, the molasses concept, because of environment, because of people, because of kit or whatever. And we're all exhausted after jobs like that. And that's because these flow disruptions deplete your cognitive resources. But it isn't just about equipment. There's a classification framework called Ripcord TWA. I can't remember what Ripcord stands for. It's a pretty cool acronym. But TWA is threat window analysis. So flow disruptions result in threat windows, a window of opportunity for a threat to occur where something bad does happen or can happen. So reading this stuff has made me think about flow and flow disruptions, environment, and equipment in a little bit more detail. And I'm becoming more perceptive to these issues on jobs now. You can see that classification there. It's not just about equipment and environment, it's communication, coordination, and so on. These papers are really worth having a look at. It does change the way you think about it, or at least provide more depth to how we think about this situation. So, you know, if we're setting up for a cardiac arrest in hospital, we'll think about where we position stuff to minimize those flow disruptions. All right, now I'm going to introduce you to Fernando. Richard knows him. He just mentioned him earlier, coincidentally, but he's a senior nurse in an emergency department in Kent. And they had some funding when they built a new hospital for a new resus room. And he said, can I design it? And they went, all right. And he's quite interested in human factors. So the left of the screen to his right is where they set up all their airway stuff, all the airway equipment, color-coded plan A, B, C, D. And this is where they do their drugs, all the labels and stuff. But the cool thing is how he does the drugs. So there's a drawing up area there with everything they need, and they'll draw up the ketamine and the rock in standard syringes with the colored labels, but then they'll put them in a colored tray that corresponds to the color of the drug label. So when you go for the ketamine, you will only ever reach in that yellow tray, and the nurses will put the ketamine or the etomidate or the propofol in that yellow tray. The rock or the sucks will be in the red tray. So in terms of engineering away from certain flow disruptions, that's one nice little human factors example of the system. And of course, we think about all this stuff all the time. The way that the packs have been designed with the pack update takes a lot of this stuff into consideration as well.
But he's also got the other, like the hospitals in the trust where the trains often rotate to. So ED may take exactly the same.
Brilliant.
In the other two hospitals, we often rotate to there. So
great.
There's a load, you know, going down. It looks the same.
Mm.
The outline cables.
All right. I promised to tell you about this amazing woman born in 1878. Her name is Lillian MH Gilbreath. And she's done a lot of work on flow disruption engineering. In fact, she kind of invented it. So did her husband, Frank. And Frank was an engineer, and he was very interested in working more effectively. Lillian was an engineer, but also a psychologist, and she was one of the first women in the US to get a PhD in psychology. And together, they did a lot of work looking at processes, starting with industrial processes. So, for example, Frank was interested in bricklayers and construction, and would have a look at scaffolding design and where bricks were laid and how people working with scaffolding could access their stuff they needed to lay bricks more efficiently. Because before these two did this work, this big industrial machine that was trying to get more efficient in the US was all about time. It was like, how do we make you quicker? I know, we'll make your break shorter. We won't let you talk to each other during work, and to try and cut time things. But these people, this couple, invented time and motion studies. They weren't just interested in how long things took. They were interested in how efficient they were by how you moved and where you placed stuff and how you engineered your environment. So they invented the time and motion study. Lillian went on to look at operating theatres, and she studied surgeons doing operations. This is sort of in the early 1910s. And she documented that surgeons spent most of the time during an operation trying to find the right bit of equipment. And she said, you know, if you put all your equipment out at the beginning and had it already sterilized for each operation, you'd be a lot more efficient. And actually, if you had a nurse there to help you find stuff and hand it to you and make sure it's not still in the patient afterwards, you'll be more efficient. And so she kind of invented surgical equipment trays and operating theatre nurses, and a whole bunch of other stuff as well. Frank and Gillian had 12 kids, and they saw that home environment as a kind of laboratory for testing all of their efficiency stuff. So getting all the kids fed and to school and washed and stuff. They had processes in place to make that possible with 12 kids. 2 of the kids wrote a book about their experiences called Cheaper by the Dozen, which has been turned into a movie at least 3 times, resembling the original book less and less with each iteration. Now, she went on to get involved in a load of other stuff. She interviewed 4,000 women and how they worked in the kitchen. And she's now responsible for the standard 900 millimeter bench height in kitchens around the world. She's the one who put pedals on pedal bins. And she also thought the fridge door would be a good place to store stuff in the fridge to be able to get to it quickly. And the tray that your eggs go in, and the little thing with the lid on that butter go in, those were her inventions, as was the idea of having light switches on the wall instead of on the lab. So she's done a lot of stuff that influences the way we do a lot of things from day to day. And interestingly, she and her husband collaborated on a lot of projects and would present them at conferences and publish them. And often her name was left off the publication, and often he would do the presentation because she was a woman. And interestingly, she had a PhD. He'd never even been to college, but that's how things were in those good old days. Anyway, that is it for the 5 things. The 0-point survey you know about. Relational coordination is this way of high-performing organizations making sure people share knowledge, share goals, and have mutual respect. And you can build that into a small ad hoc team on a micro level with a standardized pre-brief, looking at what we know, what we might have to do, what might change, what are the roles, does everyone know each other? Mental models, which help us set the mission trajectory, are really more than just this is what's going on and this is the plan. It's about communicating at a deeper level so that we're all encoding information in a way that helps us have a similar picture about what's going on, but also about understanding what that means and predicting its implications in the future. I'm a big fan of an after-action review because every high-performing unit in whatever domain does that and sees what it can learn in a non-judgmental fashion. And I wonder if that's something that we could formalize more in this service. And then when we think about controlling our environment and communication and systems, we should be continuing to minimize flow disruptions and honoring Lillian in that process. Okay, that's it. If you want to pursue any more of these references, there's the QR code now.